Many of you, a man who can do the back of the eye and the front of the eye, and is a known expert on cataract and refractive issues. So thank you, Oliver, for talking about the standard and old-fashioned approach.
Thank you very much. I have no financial disclosures which are relevant. I guess you two, Alistair and Jan, had a good laugh when you gave me the topic of the AC IOL, because it's a little outdated, and that means also boring. It's like a dead duck. So thank you very much for that. My last AC IOL was actually in 2009. We don't have an AC IOL lens bank anymore since several years. But now obviously I had to go into literature and we'll see. But I want to talk about the types of AC IOLs, essentially the history of AC IOLs, because that's relevant, because many of the lenses we're explanting today are actually quite old AC IOLs. Then about the adverse events, and also about refractive outcome, just briefly at the end. So here you can see the first lenses out in the 50s, Stampelli, Choice, Dunheim, Ridley, severe corneal decompensation, severe uveal reaction because of erosion of uveal tissue, a lot of inflammation. Then Baracare came out with an open AC IOL with nylon haptics, and these actually biodegraded and caused decentrations and also other problems. And then came also some sort of closed loop haptics with semi-flexible loops, but again, problems with the iris and also uveitis. And then essentially came at some point the flexible open loop haptics. Of these, there were also the Kelman types and the Dubrov style, and then the one we essentially use today, which has these choice type foot plates. These are the ones which we're still explanting today. One of the problems is these small openings, these eyelets, which also sometimes cause fibrosis with the uveal tissue and actually make explantation quite difficult in some cases. So just these closed loops, I think they're the main reason for the poor reputation of AC IOLs. Excessive vaulting, fibrosis, as I just said before, corneal decompensation in many cases, and chronic inflammation with CME, glaucoma, and they were also removed from the market in the 80s, and then again came the open loop haptics have a small area of contact. You can see here the implantation ratio. So at that time, of when this publication came out, most AC IOLs that had been implanted were open loop, and the closed loops were a smaller part, but they had a very large ratio of explantation. You can see here that these closed loop lenses had really significant reasons for that explantation, especially inflammation, corneal problems, and CME. Let's go look through the adverse events in sort of a more systematic fashion. There's one randomized control trial. There are not very many trials about AC IOLs, as you can expect, but there's one large trial by Collins with 438 eyes. What he did is he had obviously patients with capsular rupture and vitreous prolapse, but sufficient capsular support also for a posterior chamber IOL without sutures. He then randomized into posterior chamber and AC IOLs. 1 year follow-up. And essentially, when you look at most of the complications, there are actually no significant difference between the two groups. For visual acuity, there is, so slightly worse visual acuity for the AC IOL groups, but not much. Another very recent publication by Doug Koch's group, a retrospective consecutive series of 167 eyes, now comparing scleral sutured, iris fixated AC IOL, sulcus placement with optic capture, sulcus placement without optic capture. These are the early adverse events, and you can see very, very little for AC IOLs, actually the lowest number for AC IOLs. If we look at the later adverse events, we can see that these are a little higher, but still quite low. So they actually summarize that obviously sulcus placement is the number one what you should aim for, but that the three others, whether scleral sutured, iris fixated, or AC IOL, actually are pretty much the same, not much more difference. And actually scleral sutures seem to have higher complication rates on adverse events in this series. Now sizing is obviously an issue with AC IOLs. The sort of rule of thumb is take the white-to-white diameter and add a millimeter. The problem is that there's very few centers that still have a lens bank with different sizes, so many only have one type at this point, and usually the larger AC IOL. But ideally, you would have them in different sizes. You can have oversized or undersized, And I'll go into those problems. Obviously, oversize can cause pupil ovalization. Here you can see also quite high numbers in some of the series which were published. And then uveitis, glaucoma, hyphema syndrome has been first described in the late 70s, actually for one specific ACIOL type, and has been seen obviously with other ACIOL types. But you can also see it with posterior chamber positioned lenses, especially if they're in-out. That means one haptic is in the capsule and the other one is out in the sulcus. Then that often can cause UX syndrome. Here the reasons for IOL exchange between 86 and 2002, and you can see for posterior chamber lenses it was usually decentration dislocations or refractive errors, and for the ACIOLs which needed to be explanted, it's UX syndrome and persistent iritis in these cases were the main reason. Now what about undersized? If it's too small, well that happens, it becomes mobile, it can do propellering, it can move. And also probably during eye rubbing, especially also during saccades, there's slight microcurrents against the endothelium, and that's probably one of the reasons for endothelial cell loss. And here you can see now a series for 5-year follow-up. Here in this case comparing the endothelial cell counts with phakic controls, which is not really fair. What you really should do is actually compare it to at least controls which also had cataract surgery. And you can see here for primary ACIOL, with that control group, there's actually no difference at 5 years. Only for secondary implants, there was a slight difference. So actually here with modern ACIOLs, the endothelial cell loss, at least at 5 years, seems to be relatively low. And here also looking at 2 years from the first exam to the second exam, also essentially no difference in endothelial cell loss. There are, of course, always some persistent corneal edema cases, but again, here you can also see that for the anterior chamber lens in general, looking at all complications, actually less complications than for posterior chamber lenses, in this case, sclerofixated sutured lenses. One thing is also what you need is an iridotomy or iridectomy, and one issue can be if it's undersized that it actually will rotate and then one of the haptics can disappear in the iridectomy, which will cause a decentered and tilted lens and often can also cause UX syndrome in these cases. There is one small series of 8 patients with actual suturing to the iris to actually stop rotation of the lens, but propellering of the lens, which would be an option if you don't want to explant the lens. Looking at IOP, you can see here again a series in a trial, AC versus sulcus fixated lens again, and you can see that the IOP rise is pretty much the same in both groups. And obviously interesting is glaucoma escalation. This is actually an AAO report from a few years ago, and what you can see here is that the glaucoma escalation or progression towards glaucoma was the same for both ACIOLs, sclerosutured or iris sutured. Again, we're always talking about modern ACIOLs, not the old type. Here, refractive outcome, the paper by Brunnen again, and what you can see here is within plus or minus a half a diopter, within plus or minus 1 diopter, and you can see here we're actually very, very close to all the other types, whether it's suture fixated, iris fixated, or scleral positioning with or without optic capture. And actually we're very close here to what the UK defines as where we should be for capsular bag positioned lenses. So these are the pros and cons, the way I would summarize it. I think ease of insertion is clear. ACIOLs are the easiest to insert. That's also what we would like our trainees to use at the beginning. Obviously, as both scleral fixation and iris fixation is a little more fiddly. The operating time is probably the shortest for the ACIOL, although a retropupillary iris artisan lens can also go in very quickly. Incision size is obviously something which is good for the scleral position because you can use foldable lenses. You will need an iridectomy, iridotomy. For the ACIOLs, you don't need that for the other two. Centration is usually very good, which can be a problem and a bother with the other two. Subluxation doesn't happen here, but can happen here because of suture breaks, as Jeremy just pointed out before, or also here desenclavation, especially if the patients have trauma to the eye after surgery. And corneal decompensation is what we just have in our minds as being one of the main drawbacks of ACIOLs, and the question really is, in the studies, it doesn't really come out with modern ACIOLs. So it's